Good afternoon. My name is Paulo Neves. I'm a Portuguese cardiac surgeon. It's my pleasure to present you the current short and midterm outcomes of the live procedure for the treatment of ischemic heart failure. So starting with the background, we know that ischemic cardiomyopathy is the most common cause of heart failure and reduced ejection fraction. In patients with symptomatic heart failure and low ejection fraction, concomitant LV dilatation and transmural scar, a procedure called less invasive ventricular enhancement can be considered to placate the scar, to decrease left ventricular volumes, and consequently decrease the left ventricular wall stress according to Laplace law. This will correspondingly increase ejection fraction and also improves heart failure symptoms. So this procedure, the live procedure, has evolved over the years from a full medium sternotomy and procedure done on pump with cardiopulmonary bypass to a hybrid transcatheter procedure that requires a minimally invasive surgical approach through a small left thoracotomy, and it's carried out without cardiopulmonary bypass. So it's a half pump beating heart procedure. So the left ventricular reconstruction is achieved by implantation of a series of micro anchors to create a longitudinal plication of the left ventricular scar. We can see that over here in this picture. So this middle image represents a ventricle with a very important scar that was plicated by the system, by these micro anchors, with an internal anchor here delivered through the right ventricle up to the right side of the interventricular septum, and the corresponding external anchor is delivered by the cardiac surgeon through the small left thoracotomy. So this procedure actually allows mainly 3 implantation options according to the scar anatomy. So we can do what I've just described, and we call it the internal RV-LV anchor pair. So that's represented over here. We can use an external RV-LV, which is represented over here, or we can do a purely surgical approach with an external LV reconstruction. So this procedure normally uses a combination of 2 or 3 of these techniques according to the individual scar, and actually allows us to tailor the procedure to each patient, making the treatment really individual. This latest iteration of the technique also addressed the procedural complexity that was present in the past while maintaining its efficacy, and solved also some issues on bleeding and tricuspid injury. So in terms of the results of the latest iteration, so between July 2018 and November 2020, 72 patients were treated with the live procedure in 15 centers in Europe and Asia. Procedural success was 100%, and average duration was 137 minutes. So a mean of 2.4 anchor pairs were used, with a median of 3, to adequately reshape and remodel the left ventricle. Looking at efficacy, so after the procedure, on average, end systolic volume index came from almost 72 milliliters per meter squared to 44, and end diastolic volume index came from 97 to 65 milliliters per meter squared. Correspondingly, ejection fraction went from on average 30% to more than 39%. It's very important to say that 90% of these patients had an end systolic volume index of 60 milliliters per meter square or less. And as we know, this is associated with better survival, as was studied by Mickler in his post-hoc stitch trial analysis. So in terms of percentage of improvement, this corresponds to a more than 30% improvement in ejection fraction and a reduction in ESVI of about 38% on average, well above the 30% cutoff that is normally associated with a prognostic impact on these patients. So looking now into safety, there were no conversions to stenotomy required or any use of extracorporeal circulation needed. There was only noted one case of TR, tricuspid regurgitation, in one patient, and this was transient. And there were no recorded cases of VSD or stroke. Early mortality was one case, 1.4%, and this was due to severe contrast-induced anaphylactic shock. And on average, during the follow-up, median NIA class was improved by 1 grade. If we look into the safety profile of the latest iteration of the technique, which is represented in this table on the right column, and if we compare it with the previous iterations, so we see a very important improvement, not only in mortality, but also in morbidity, with a total serious adverse event rate that is quite reduced when compared with the previous iterations of the technique. So in conclusion, I would say that the live procedure is effective in patients with heart failure and reduced ejection fraction after a transmural myocardial infarct. The latest results of the technique demonstrate its improved safety, efficacy, and reproducibility in treating ischemic heart failure in those patients. Thank you very much.